Hi, this is your producer, Kadisha. Before we start, we'd like to note that we discuss sensitive subjects that might be distressing for some listeners and readers throughout this episode. Please be aware that the content includes discussions about medical discrimination, racial health disparities, testimonial injustice, and ableism. Your well being is our priority. If these topics are triggering for you, we encourage you to consider seeking support during the time you engage with the content or choose to skip this content overall. Take care of your emotional well being and prioritize what feels right for you. Now, on to our episode.
Doctors with disabilities exist in small but measurable numbers. How did they navigate their journey? What were the challenges? What are the benefits to patients and to their peers? What can we learn from their experiences? My name is Lisa Meeks, and I'm thrilled to bring you the Docs with Disabilities podcast. Join me as I interview docs, nurses, psychologists, OTs, PTs, pharmacists, dentists, and the list goes on. I'll also be interviewing the researchers and policymakers that ensure medicine remains an equal opportunity profession.
Hi, and welcome back to the Docs with Disabilities podcast. In this two-part series, we are joined by Dr. Diana Cejas, pediatric neurologist and a faculty of the Carolina Institute for Developmental Disabilities. During her time in residency, Dr. Cejas was diagnosed with a rare form of cancer which set her on an unimaginable journey. In this very honest and vulnerable episode, Dr. Cejas shares her troubling experiences with obtaining her diagnosis, navigating the demands of residency, and advocating for herself as a person with a disability.
My name is Diana Cejas. My pronouns are she, her, hers. I am a pediatric neurologist at the University of North Carolina at Chapel Hill and faculty of the Carolina Institute for Developmental Disabilities.
I'm so excited to finally have you one-on-one. We have introduced you with the amazing Alice Wong as you were part of her anthology series. And then you did a podcast interview with my co-host, Pete Poulos, with Dr. Justin Bullock as well. Today, we're giving you the full stage as you rightfully deserve. And we're just going to have a conversation about you, your experiences, what it means to be disabled in medicine, what it means to be Black and disabled in medicine, and how that really affects you. I'd also like to talk to you a little bit about the leadership roles that you have. I know you have a leadership role with our organization. You also fill important leadership roles in other organizations. And I'm so grateful for that and for all of your writing and your advocacy. So I want to talk some more about that. And then we will end with the advice that you have for our listeners. So let's start with maybe a little bit of background for those that haven't heard you before, haven't heard you speak before about your disability.
I feel like I never know where to start because usually I'll say, oh, yeah, I'm disabled. I'm a cancer survivor, stroke survivor. And then I just watch people's eyes either get big or get confused. So then I feel like I have to give the backstory. So yes, I'm a cancer survivor. I am a stroke survivor. Both of those things happened while I was in residency. So, if you want something to radicalize you, that's definitely going to be it. But I feel like there's even more backstory to that. So I initially found my tumor when I was in my first year of medical school and don't remember exactly when it was. I do remember that it was there for a little bit of time, and at first I just kind of brushed it off. Ultimately, I ended up literally asking my friends as we were standing outside of anatomy lab, I said, hey, can you take a look at this, see what you think? And at that time, I already knew that I wanted to go ahead and get it checked out, but of course, I'm being stubborn. they all kind of poked around and they were like, yeah, that doesn't feel great. We're first year medical students. That's about the limitation of our diagnostic skills at that point in time. And they said I should go get it checked out. So I just took that as confirmation of what I already knew. Little did I know that that was going to set off this 5-year path of me trying to get the healthcare that I needed, trying to get someone to take my concerns seriously. I went to our student health office first. I can't tell you how many different doctors I talked to, both at student health and then later when I tried to get other physicians to take a look, take things seriously. And every single time it was like, oh, you're just anxious. Oh, that's just a little bit of lymphadenopathy. Oh, maybe you have an infection. Or, oh, you're a medical student. Of course you think that you have whatever condition it is that you're learning about that week. And again, at first I had very limited options. I was relying on our student health system because I didn't really have any other choice. It's not like I had other insurance. It's not like we could really afford to go to other physicians. I scraped up a little bit of money later and as a favor ended up seeing some who were outside of that system. But the other thing was I was in medical school. Some of these people were my attendings. They were people that I worked with. So I thought, if they're saying it's nothing, it's nothing. And did a lot of doubting myself, at the same time recognizing that there was something that was going on. And on the one hand, trying to push for it, on the other hand, trying to push against it because I was scared. And I thought that there might be more going on than anyone was thinking. So went all the way through medical school with this thing in my neck. It kept kind of growing. At first, I had no symptoms. Then I later started to have symptoms, which, of course, I was in residency by that point in time. I said, oh, I'm tired because I'm in residency, which, valid. Or I'm not feeling that great right now, or I'm dizzy, or I'm weak. And I would say, it's because I haven't eaten. It's because of this. It's because of that. As the mass started to grow, it actually started to become painful. And even though describing pain is literally part of my job, I still have a hard time describing exactly what it felt like, other than to say that it was painful and it was just present. And it got to the point where at first it was present, but I could ignore it. But later it got to the point where it was present, I couldn't ignore it no matter what I did. I had moved cities by that point in time, had a brand new set of doctors or a brand new primary physician. Remember talking to her multiple times and got the same kind of thing. Oh, it's nothing. Oh, you're anxious. Oh, you're a resident. Just think about it being, literally anything but what it was. And specifically, I remember that there was one day when I was post-call and it had been usually, when I was post-call, I would go get some greasy food, try to eat as much as possible, and then go to sleep as soon as I could. But that particular night, hadn't slept at all. I was on call or awake for more than 36 hours. Came home, ate something, got into the bed, tried to sleep, and I could not sleep because it was so painful. No matter what I did, no matter what position I was in, I kept trying to move, and it just kept bothering me. So I said, okay, walked into work exhausted the next day because, of course, I had to go back to work after my post-call day. And I said, I cannot do this anymore. Something is happening. I have to find out what. So I made another appointment to see my primary doctor. And that time I tried to say I was going to approach it a little differently. So I presented myself as if I was presenting a patient. By that time, I was in my second year of residency. And I said everything that I would say as if I was talking to my attending and trying to convince them this is a patient who needs to have some kind of workup. So I did that. And I remember at the end of the conversation, she was like, yeah, that definitely sounds like something that I would look into, but it's nothing. Don't worry about it. And tried to, send me out the door. And I had a little bit of a hissy fit. Again, I was post-call that day, of course. So I think I was a little tired and I was a little tired of hearing the same thing. So I was just like, you have to do something. There has to be something. Just humor me, please. See what's going on. If it's nothing, it's nothing. It's fine. But I really need to know what's going on at this point. So I think just to shut me up, she was like, all right, we're going to get a CT scan and then everything's going to be fine. So put in the order for the CT scan. I think the next day or the day after is when I decided to go get it done. I was rounding. I came down to the second floor to get the CT done. I remember looking at the tech through the window and seeing that they had a weird look on their face. And I was like, that's probably not a good sign. And then I walked upstairs to try to see if I could wake myself up a little bit. Walked from the second floor to the fourth floor where our unit was. By the time I got to the top of the stairs, my doctor was paging me to say that we needed to talk. And so after, because, of course, I had to finish up with my duties, I said, okay, I will come down in a little bit. I remember going into the resident workroom, saying that I was going to be finishing my notes and pulling up my scans so that I could see them. And that's the first time that I saw the mess on any kind of imaging. I took a picture of it and sent it to a friend and said, hey, what do you think this is? And he actually told me, oh, I think that looks like a paraganglioma, which is what I ultimately was diagnosed with. And he was like, which patient is this? And I didn't say anything. So came downstairs later, talked to my physician about everything. She was like, yeah, it looks like a carotid body paraganglioma. I've never even heard of that before, but you need to go and see some surgeons.
In academic medicine, the refusal by healthcare workers to recognize knowledge and beliefs of patients for reasons associated with their social identity has been studied and described as epistemic injustice. As Dr. Cejas illustrated, it can have severe consequences, such as delayed diagnosis. In 2023, a study by Brown and colleagues with Black patients regarding the association of racism with communication and decision-making during serious illness, participants described knowing their bodies yet having their experiences silenced and dismissed, often feeling that healthcare workers did not value their perspectives. Their study found that epistemic injustice was not only a barrier to equitable communication and care, but that it also contributed to the erosion of trust in healthcare workers. In this segment, Dr. Cejas bravely shares lessons she gained that would later inform her practice as a physician.
So that kind of started the whole thing. It's a pretty long, and I know that was long, but a much longer story with, I got, my radiology diagnosis, ended up seeing some surgeons. There was a lot of kind of back and forth as to who was going to do my surgery. Ultimately had my first surgery, which removed the tumor. We had thought that everything was good. Everybody who saw it thought that it was going to be benign. But then when I came in a week later after my first surgery to get the stitches removed, that's when my surgeon told me that it was malignant. And specifically, even that was another opportunity now, certainly not in the moment, where I kind of took what I don't want to do from that person's kind of style of delivering that news. So he had taken out my stitches. I was still in residency. Of course, I wanted to see the thing. So I had asked him to take photos while he was in the operating room. Showed me the photos, talked about the work that he did. He was like, oh, it was amazing. I did all this work. It was great. I thought we were done. I get up, stand up, get ready to leave, have my purse in my hand. He says, hold on a second. You got to sit back down. We need to talk about something. When I was in there, I found 3 lymph nodes that were lying on top of the tumor. I sent them off to pathology. We found out there was tumor in the lymph nodes. I'm going to get somebody to talk to you about this. And then he left. And I hadn't even brought anyone into the room with me because I thought that I was just there for a stitch to get my stitches out. And literally it took less than 2 minutes to tell me, as I'm thinking I'm walking out the door, that I had cancer. So again, in the moment, that was awful. Looking back, it's still kind of awful, but I like to think that good things that have come from that are that I can see how that made me feel as a patient and try not to replicate that in my own practice now. And I think one of the biggest things that I've learned with my whole diagnostic journey, everything that has happened before, the best thing about that and the whole experience is that I feel like since I was still in residency, I was pretty malleable and trying to figure out what kind of doctor wanted to be, trying to figure out how I would practice myself. And I think that so many of the interactions I can look at now and say, hey, I see where I took this and said I wanted to learn kind of what not to do. Because certainly with the patient population I work with now, I work with a lot of kids with neurodevelopmental disabilities, lots of kids with neurogenetic conditions. Some of them are particularly rare. There are going to be times when I see a patient where I've never heard of that condition before, or maybe I only have heard of it once, or I'm not as sure about the management because it is such a rare condition. But at the same time, hearing my doctor say, I've never heard of that before, kind of excitedly, colored, I think, the way that I approach even working with the rare conditions, working with the rare tumors now. Because I remember just feeling in that moment so unsafe, feeling like on the one hand was like, I was right. I told you something was wrong. But now I'm coming to you for help. And you're like, oh, I don't even know what this is. Go see these other people. Ended up going into the kind of cancer diagnosis, workup, management pathway. About a month after my first surgery, I had my second surgery, which was attempting to remove all of the cancer. That got complicated, which is another long story. And ultimately, unfortunately, one of the complications was that I had a stroke. So I remember waking up in the PACU, everything before the stroke. Everything seemed like it went well, although my surgeon, a different surgeon, thank goodness, told me that there were complications, told me, that there was some damage to one of the blood vessels that was in my neck, but they thought they had everything under control. The fact that I woke up and I was asking for things and following commands, everybody took as a really good sign. And I just remember feeling off and I couldn't figure out why. And then over the course of the day, got increasingly angry and I could not figure out what was going on, why I felt that way. The anger started to become confusion. And then the last thing that I remember clearly, which was sometime into, I think, the next evening, was looking down at my left arm, but thinking, like, why is my grandmother's arm in here? Who is that? Whose arm is that? Like, what's going on with that over there? And I remember just being so confused because I was like, my grandmother isn't even in this state. She can't fly. She's at home. So why is her arm in here? What's going on? I don't understand. Whose arm is this? Being incredibly confused. And then had just one moment of clarity where I realized that I was having a stroke. At some point in all of this, my nurse ended up calling a stroke code. The next thing that I remember after that was waking up in the ICU on a ventilator, one side completely paralyzed, the other side restrained. And I don't know if that counts as the start of everything, but sometimes it feels like it. So that's the short version of a very long story.
The intersectionality of gender and race and its impact on the health of Black women is profound. Although there have been substantial improvements to access, a 2021 study by Chin and colleagues found that disparities still persist due to what they describe as a complex milieu of barriers to quality care, racism, and stress associated with their distinct social experiences. Considering that we as human beings carry a range of implicit biases, how might naming the social processes that give rise to inequity contribute to solutions aimed at improving it? Listen in as Dr. Meeks and Dr. Cejas explore their views.
I I don't I don't even have words for what you've been through. I can't even. I'm sitting here and I'm just stunned. And unfortunately, I'm wondering if the entire trajectory of your diagnosis, treatment, further treatment would have been different if you were white.
I have asked myself that question a lot, and other people have asked that question as well. Um, Specifically, when I talk about the whole illness, my diagnosis, prior to my diagnosis, and actually trying to advocate for myself, I've had people who will ask the question, well, do you think this would have happened because you're not white? Do you think this would have happened if you weren't a woman? And I really have no idea. I certainly understand and understood before all of this happened that the way that a Black woman's concerns are treated by the healthcare system is not the same as it is with everybody else. And then, unfortunately, not even in my own personal case of not feeling like I was heard, not feeling like I was understood. As a resident, I remember getting firsthand experience of seeing other people who would come in, young Black women, young women of color, with valid concerns, valid complaints. And time after time, it was told, you're anxious, you're just being dramatic, it's nothing, don't worry. And honestly, even if it was just anxiety, anxiety is kind of a medical condition. We need to be doing something about that too. So I think it's like I want to think that it wouldn't be, but at the same time, we exist in this reality. So I would like to think that, maybe if I wasn't who I was, that someone would have helped me sooner. At the same time, I mean, even if I was, I guess I would have to be, not this gender, not this race, not this ethnicity for someone to take my concerns seriously. But then it would have been a whole different story. I mean, maybe something would have happened where someone would have caught the tumor earlier. I think it's hard for me to kind of live in this what if and just accept that people like me are not treated the way that they should be by our healthcare system. When I think about the way that we're taught to practice medicine, it's like we're taught a series of absolutes, and at the same time, we're taught, well, nothing is always absolute in medicine. It's very contradictory. But one thing I think that we're taught, but not necessarily taught consciously, is how to reinforce these biases that we have about multiply marginalized individuals. So even if it's like, oh, technically, we're talking about there are health disparities with racial ethnic minorities. We're talking about social determinants of health, X, Y, and Z. We're not really talking about the problem. We're not saying things like racism is the problem. We're saying, oh, race is associated with this, race is associated with that. It's not the race itself, it's the racism. If we're talking about, poor outcomes for Black disabled people in particular, we're not talking about race and ableism. We're not saying those things as they should be said. And you can throw it any kind of other kind of marginalization on top of all of those things. So for those of us who are living in these intersections, none of this is a surprise. None of this is unknown. I am sure that I could ask so many of my family members about their own experiences with the healthcare system, and I would get not necessarily the same, but very similar stories. I think a lot of us have cousins, who they don't trust doctors anymore because of what has happened to them in the past. A lot of us have unfortunately have cousins or family members or friends who have had negative outcomes, like during a pregnancy, people who have lost relatives because of pregnancy outcomes, people who have lost family members because things were caught too late, cancers were caught late, or other conditions that maybe could have been treatable were caught late. And at the same time, we're in medicine, we're like, oh, we're trying to do the best we can. We're trying to do the best that we need to do for marginalized groups. We're not willing to recognize how our system reinforces the biases that are within our culture and how that is harmful to patients. And then even if we do, it's like we just want to say, oh, well, but that's done now. These are things that happened in the past. We talk about atrocities that have been committed in the healthcare system. We talk about things like Jerry Marion Sims, We talk about things like the Tuskegee experiment. We talk about things as if they are all historical and don't talk about the ongoing harms that we see that are perpetuated by our healthcare system today. So I feel like that is a very long-winded way to say, yes, I think that it could have been different for me if I wasn't who it is that I am. It's hard to say exactly, but I mean, that's just kind of reality.
I ask you that question from an informed, what I think is an informed lens, and you're a physician while you're communicating that something is wrong. You are actually qualified to evaluate patients. And I think it's so interesting the way you talk about presenting yourself as a patient and to your primary care physician and still being ignored while she or he or they acknowledge to you that they would be looking this up. Yes, this is something that I would want to investigate, but for you, it's nothing. When I don't talk often about my disability or the process, I still have very mixed feelings, but I will say in the beginning of it, I had symptoms similar to you. I lived in a brownstone, a walk-up brownstone, and I would walk back and forth to the clinic every day, and I loved it. It was this lovely little walk. And I started noticing that I was getting tired, and like you, I thought, oh, it's just work. I'm just working too much. Until one day where I was out of breath when I got to the top of the stairs, and the next morning I couldn't lift my hand to wash my hair in the shower. And I remember just sobbing, not knowing what was happening. The difference is that I went to my internist, and I had been healthy. I was a runner, once a year person going into medicine for my yearly checkup. And he ran, as is appropriate, some labs. And when they all came back negative, he ran toxicity labs to see, did you touch a plant? Did you get poisoned somehow? When those all came back negative, he went from that to a full body scan at the Cleveland Clinic. A full body scan, Diana. Like, to justify that to insurance, I'm still a woman, which unfortunately for us and for women, they're not believed as much. And it's, age-old story. This is hysteria, right? Or anxiety. And as you so aptly bring up, anxiety is a condition that deserves human response, treatment options, validation, all of those things. But it's such a striking difference to me, the way we were treated. And I'm not an MD. So I wasn't qualified to evaluate myself. And it makes me so sad. And when I hear these stories repeatedly, I think, as you do, this isn't history. This is present day behavior. And I love how you said, this isn't about race, this is racism. So you have this experience both as a medical student, which is just kind of pushed aside, but then as a resident. In the aftermath of your stroke especially, which has, and I'm focused on that versus the cancer, because a stroke has visual, apparent consequences. I've seen the photos. We've worked together for several years. You talk about it so openly and you share so openly. At that point, you had something that was visible, and whether or not people perceived it or processed it as a disability, it was definitely a deficit. How were you treated in the aftermath of the stroke when it came to returning to residency, being treated as a physician?
It was weird. Um, on the one hand, I felt lucky in that I had people that were in my corner. On the other hand, I felt like I had completely lost control of the plot and anything that I wanted to have happen for myself. If there are three hands, you can say that I also was getting like the ableism crash course right in the face immediately, which shouldn't have been surprising, but I think that it was a little bit. When I talk about having some people in my corner, so thank goodness for my program directors, we had two, and both of them were 100% on board. Like, take the time that you need, whatever it is that I needed to do, however it was that I felt that was fine. And they were able to kind of shepherd me back into the rotation when I felt ready. And if I ever felt like I needed some help, if I ever felt like I needed some space, whatever it is that I needed, I felt like I could go to either one of them and we were fine. I mean, to the point where one of them, when I first came back from the hospital, I don't know what he told his wife, but all of a sudden I just know that I got a bunch of food at my door because he was worried about whether or not I was going to eat. Now, I never told him that I was still on swallowing precautions, so I couldn't eat most of it. But my mom was taking care of me, so she got to eat a lot, which was nice. But I felt like they both knew what was going on. I had told them kind of both what was going on, and they would come by and see me in the hospital. They actually, both of them came separate times, and then sometimes they would come together. But it never felt like it was invasive. Now, I cannot say that for everybody that was part of the program. I'm in academic medicine now. I understand, there are going to be times when we get a case that's interesting, quote unquote, where we see something that we didn't expect or something that is rare, something that's unique. And of course, doctors don't get excited about the common cold. I think that this is something I've said before. Maybe there's some, I'm not meaning to, judge, but for the most part, it's rare things, it's unique things, it's complicated patients. That's what we want to see. That's what we get interested in. So my tumor was pretty rare, particularly for the age group, particularly for other characteristics about the tumor. So even from diagnosis, when I first started meeting with my surgeons, they were talking about it like, oh, we're going to talk about this at tumor board. I remember meeting other residents, ENT residents in particular, who we kind of knew each other because residents often kind of know each other, even though they're in different specialties. And I remember running into some who were like, yeah, we talked about you at tumor board today. Or, oh, we were talking about this and it was really exciting. And on the one hand, it's like, oh, great. I'm glad that you're learning. On the other hand, it's like, that's me. I don't know how I feel about y'all just being like, hey, let me talk about you and your case right there. I cannot tell, I do not know how many people just kind of knew about what was going on. I remember, for the first couple of weeks after my diagnosis, it was like I became the peds resident. I was a pediatric resident at the time, but when I would see surgical residents, they're like, oh yeah, that's the peds resident who has that weird tumor. They never said that part, but it's like, I know what you're talking about. So it was kind of strange to be like a little, I don't know, not famous, but something. People knew about my tumor, about that I had not disclosed to them because of what they were, because of how they worked. And even when I had my surgeries, I remember after my first surgery, as I'm recovering in the PACU, one of my friends came by, which she knew I was having a surgery. It was okay because it was her, but it's like, you're coming by. Like, I am fresh out of the OR. And so somebody's coming in. Again, she was my friend. It was okay. But after I was moved to the floor, I remember that there were residents who would come by who were part of my program, but who I wasn't necessarily friends with. And they were just kind of showing up, and it's like, are you here to provide support? Are you here to just kind of gawk? Because that's what it felt like sometimes. And I remember one of my other friends specifically had to, I guess, fight against one of my attendings who, while I was after my second surgery and in the ICU, he was planning on bringing by the entire team during rounds. The entire team is like all the residents, the medical students, the nurses, everybody. On the one hand, cool. On the other hand, I'm in a very vulnerable state in an ICU. I had just been extubated at that point in time, and it was like, thank goodness for her for being like, that's a line that you should not cross, and her advocating for me as my friend and on my behalf. There were definitely people, attendings, residents who kind of came by who were like in my face, again, while I'm in the ICU, very vulnerable. I could not move one side of my body entirely. So even if I wanted to kind of get someone to leave, I barely could even talk at that point. So there were definitely times when I felt like, while I was actively in the hospital, people were coming by just to come by because there was something interesting that was going on, and I was the interesting thing.
Learning the contours of self advocacy as a person with a disability can be challenging, even more so in the midst of residency. Listen here as Dr. Cejas discusses her experience with self advocacy, reclaiming her story, and navigating the sometimes unpleasant terrains of accommodation requests.
One of the reasons, and I think you said something about me being so open about everything, and I think one of the reasons that I am as open as I am about everything that has happened is because me telling my story lets me have control over it. And I felt a big loss of control around this entire thing. I even remember writing a very long email to everyone. I think I was still in the ICU, typing one-handed. It was very bad. I couldn't half see. I was still drooling all over the place. But part of the reason I wanted to send that was to be like, hey, I know that y'all are hearing. This is what's going on. Because I don't want you just out there taking my story, talking about me and all that other stuff. So it was very, very strange to be at this hospital where I worked, know that people knew what was going on, and who would talk to me kind of as if I had already told them something when I hadn't, and I didn't always feel comfortable with them knowing those things. Let alone the fact that I'm in there in a hospital gown, who knows what's hanging out, and people can just kind of come by and see me in this very, very physically vulnerable state, not to mention mentally vulnerable. So it's like I feel like I'm supported. At the same time, I felt like I was kind of on display sometimes. And then the whole ableism thing was an issue. I think I was optimistic, and even not so much now, but certainly when I first got into medicine, I had idealized thoughts about what medicine could be and what it could do. And when I first got my diagnosis, I just assumed, you know, we're doctors. We're going to know what to do to support a disabled or a sick resident. Specifically, especially because there was a resident who I think was in internal medicine at the time. I can't remember exactly, who had also had a critical illness. And I remember, even though I wasn't in that program, it seemed like everybody was rallying around that person. I wish I could talk to them now to find out exactly what happened, because I assumed that, hey, there's something that's going on over there. This is very similar over here. Y'all are going to know what to do. But literally no one knew what to do, what to say, how to accommodate things. People would say things, and I think maybe they meant it in a nice way, but it's like benevolent ableism, or people would assume that I couldn't do something that I could. People would assume that I could do something that I couldn't. When I started asking for accommodations, I was treated as if I was asking for a special request. The biggest blow up that I had was I was having trouble typing. So my left side was still in recovery, was not moving that well yet. I had frozen shoulder syndrome on the right side, so my right side is dominant, but I was still having a lot of trouble with physically typing when I came back to work. And it was to the point where I was on a rotation and an attending was like, I'll be your scribe. And they started doing a lot of typing for me, which I'm thankful for that person. But at the same time, I'm like, this isn't how this should work. So I remember asking for an accommodation, and I think I had tried dictation software, but at that time I was still really dysarthric as well. So it wasn't working for me. So I said, I just need something, anything. Maybe y'all know what to look for, because I certainly didn't know what to look for. And remember going to someone that I trusted, asking for this accommodation. And they said, well, Diana, you're going to be a neurologist, right? And I said, yes. And they said, well, nerves take a long time to heal. So maybe you just need to be practicing a little bit more. And at that point in time, I was still in OT. So I'm in residency. I am in recovery. I am going to all of my follow-up appointments. I was in physical therapy, occupational therapy, speech therapy, trying to juggle all of that around residency. And my occupational therapist, her son was actually a physician. She knew how important it was for us to be able to do notes. So a lot of my exercises were actually based on typing. So it's like, not only am I practicing, I'm practicing as part of my occupational therapy rehab. And I just remember being like, you were there. This is a person who had literally seen me. I remember being on the ventilator, looking at this person through the window. You know what has happened. You have seen what has happened. I'm asking you not for help, not for you to do my job. I'm asking you for an accommodation that I need to have so that I can do my job. And that was like the first where I was like, oh, so this is kind of how it is. And then I remember, there were times when I would need to leave because I have to get a CT scan or a PET scan, or I had to do a follow up or something like that. So I would try to arrange it so that all of my work was done. I had coverage, there was backup so that I could leave for like an hour to go do something because, of course, I can't do it on the weekends. And I was on a protocol. I couldn't do it at a specific time, but there were emails that were circulated that were like, you need to do to the whole residency, but we all knew who we were talking to. You need to take care of personal appointments on personal time. Like I was just going to go get my hair done or something like that, which you should be able to go get your hair done as a resident too. Like it's okay to take care of yourself. But it's like, I'm literally telling you, I need to go get a PET scan because I had cancer. I've gotten all my work done. Why is there this pushback? So coming back to work was weird for a lot of different reasons. I was already trying to, of course, struggling with my own internalized ableism. I'm struggling with the fact that now I didn't know how my body was going to work, worrying that cancer was going to come back, worrying about the stroke because also nobody knew, well, we kind of knew why I had the stroke, but it was still some murkiness around that. And then it's like, I'm trying to be a resident. I'm trying to graduate from residency. I don't know what my life is going to look like now, and I have to deal with all of this on top of that. I don't know exactly what word to use for it other than strange. I'm definitely glad I'm not in it anymore.
Thank you to our guest, Dr. Diana Cejas, for candidly sharing your experience with our audience. To our audience, thank you for joining us. If you've enjoyed this discussion, be sure to subscribe to our podcast, check out our previous interviews, and tune in again next time for part 2 of this 2-part series where Dr. Meeks and Dr. Cejas keep the conversation going. This podcast is a production of the Docs with Disabilities Initiative and is supported in part by the University of Michigan Medical School Department of Family Medicine Disability Initiative, the Stanford Medicine Alliance for Disability Inclusion and Equity, the Ford Foundation, and the Robert Wood Johnson Foundation. The opinions on this podcast do not necessarily reflect those of the hosts, their respective institutions, or the funders. This podcast is released under Creative Commons Attribution Non-Commercial Non-Derivative License. This episode was produced by Kadisha Trico, Jacob Feeman, and Dr. Lisa Meeks.